Hello, everyone. Again, sorry, we're having some kind of technical hiccups. I just want to call it. So welcome back. We are going to again hear Dr. Prpich talk about shared decision making. So much importance on that. So again, for all the presentations, everything is being recorded and it'll be available later at our Florida Asthma Coalition website and our YouTube channel. So once again, Dr. Prpich.
Hey guys, all right. Okay. So, and I did want to echo the, going back to the YouTube channel, going to the website, right? All the old recordings. We really, over the years since we've been doing the virtual, the last 2 years, and now this hybrid format, right? We're starting to accumulate, I think, a really nice library of previous lectures that have been given at previous summits, and they really are very, very good. So it's an excellent resource. It's free, and I mean, so I definitely encourage you to go check out the YouTube channel, look at previous talks. And so, the theme for today, right, was shared decision making, and so I figured I would try to tackle talking about it in a busy clinical practice. And just to give you perspective, right? So I'm a pediatric pulmonologist. It's myself and one other physician, and we have 4 nurse practitioners. We have a very busy inpatient service, and then in clinic, we book about 120 kids or so in a day, just in our clinic. We'll usually see anywhere from 80 to 90, some days over 100 kids in clinic, right? Plus maybe 20 or so in the hospital. So I just bring that up to sort of say that it is a possible thing to do in a that kind of pace. It's not something, of course, you're not doing this kind of in-depth with every single patient, right? But it is possible, but it takes it takes a lot of multitasking. And so when I was putting together this sort of talk, this is a very different talk than any talk I've ever given, right? I'm more used to giving more, medical informational kind of talks. And when I was thinking about this, it was sort of, at least I took it as sort of how do I conceptualize talking to my patients? How do I sort of conceptualize educating my patients, trying to help them, help make decisions? Because really, ultimately, the biggest thing is there we go. If we can go for there we go. So biggest thing is what are the goals? Why would we do it? So we're going to talk a little bit about factors that impact asthma control, because ultimately that's what we're here, right? We're trying to take better control or take better care of our asthmatics. Talk a bit about medication adherence, because that framework, this idea around medical decision making, I mean, it's around education, it's around empowering families and empowering patients, but ultimately it's about helping, hopefully, provide better adherence to our medications to provide better outcomes, right? And so the obligatory slide, right, in terms of asthma, this is, more Florida specific, right? 1,200,000, patients in Florida with asthma, 1 in 13 Americans have asthma. But unfortunately, and we all know this as well, right? It differentially impacts patients that are lower income households, more African-American, Puerto Rican, children's and adults. So it's skewed in terms of the both socioeconomic status and racial groups that it affects. And when we talk about asthma in Florida, and we've seen sort of different versions of some of this data, but it, up to at least as of 2020, 44% of our children with current asthma, it was considered uncontrolled, right? So this is, and when you look at that chart compared to other states, there's a few states that are worse than us, but we certainly are not, on the lower side. That's a pretty high rate when you think about uncontrolled asthma. And the 800-pound gorilla in the room when we think about uncontrolled asthma really is around, of course, diagnosis, but more importantly around compliance, understanding why are we still struggling with having, we have a lot of medicines. I tell families, I have a lot of tools in my toolbox to get your asthma under control. So why do we still struggle with getting asthma under control? And what are the factors that play into that poor adherence? What are the factors that play into sort of poor inhaler technique? And then how does that impact asthma control? And when they ask families, when they ask patients and trying to look at their own knowledge, this sort of doesn't, yeah, you can really read that up there, but really the idea is, asking them sort of their understanding. A significant number of patients with asthma still don't really understand why they're on the medicines that they're on. They don't understand that they're supposed to be doing them on a regular basis. Really that tall red line is 50%. So less than 50%, the significant number of these questions, and really some over, depends on the question that you're looking at, really just don't understand the entire purpose around things. And when you look at those modifiable risk factors around asthma control, a lot of it is around whether they're getting prescribed the appropriate medication, and then beyond that, are they adherent, right? Adherence is such a problem that we have with our asthmatics, and that just impacts our asthma control. And when you look at measures of asthma control, inadequate or insufficient prescriptions, non-adherence, and inhaler technique really fall in sort of the highest in terms of what's a risk factor for uncontrolled asthma. And that's just sort of a word thing. So these were animated, but they're not animated now. That's okay. So really, when you look at reasons for patients to be uncontrolled, right? So whether or not we're appropriately diagnosing the asthmatic is a main one, right? So provider underdiagnosis, under treatment, are we assessing whether or not their asthma is controlled once we've made that diagnosis? And then patient adherence, right? Are they taking the medicines we prescribe? But depending upon what studies you look at, that adherence rate can be as high as, or as poor as 60%, right? So families just don't take medicine. I mean, sometimes it's as simple as that. And that, unfortunately, if you look at different diseases, asthma and COPD have one of the lowest adherence rates. And really, in order to achieve control, at least our best estimates are, that we need an adherence rate much closer to greater than 75%, which is just challenging. And so the reason why I think I bring all that up is that when we're talking about that discussion with families, when you're talking about sort of making decisions about medicines and trying to inform them, it's with one of the purposes is hopefully that then they understand, they buy into the entire treatment plan, and then they're adherent, right? But I said there's multitasking, right? So it's not just that you walk into a room and you see somebody and you're like, oh, they're not taking their medicine, when you drop the mic and you leave. There's more to that, right? There's different forms of non-adherence. There's different reasons why they may not be taking their medicines. Sometimes they just forget, and I'll have an open discussion with the patient if they're old enough. I'll have an open discussion with the mom if it's someone younger, because you got to do this in a very non-threatening way. You've got to really start the whole visit in a non-threatening way. You got to tell them that, that we're here for the same reason. We really want for your child to, or for the patient if it's an adult, to have good asthma control. But you need them to tell you what's going on and what's going on in their head, right? So you've got those patients that are sporadic, they just forget, to take their medicine. That's actually a pretty common one, especially with our teenagers. We work pretty, to try to find ways. I'll have them say, okay, tell me about your day. What happens when you wake up? Where does your inhaler sit? Does it sit in a drawer? Is it out of sight? Is there something that you're already good at doing? Do you brush your teeth every day? Do you pick up your phone the first thing and put your daily controller medicine right next to that? Try to link it up to something that you're already good at doing on a regular basis. There's apps, there's medication reminders, there's tools that we have, but that sporadic sort of I just keep forgetting. And I get to ask, I was like, look, would you take it if you could remember it, or is it just something you just forget to do? There's of course people that are deliberate. They just don't want to be on medicine, or they're worried about it, fear side effects. And so if you're as you're talking to them and asking them about that, and you start to get that kind of feeling, that you've got a very different sort of road to go down than just telling them to put it next to their bedside table, right? You've got to explain to them so that they understand why they're on the medicines that they're on. And then, just even people that they just don't understand. They would do it if they knew, they just don't fully understand. But you've got to get them to tell you that. You can't assume that they're just not adherent, that's all for the same reason. And we know that patients' perspective of what is controlled and how their asthma is doing is very heavily skewed, right? So you can see over there, kind of to your left, right? So that's the patient perspective. And 40% of these, when they did these questionnaires, they thought their asthma was well controlled. 31% thought that it was completely controlled. 24% thought they were. So really, that's a huge part of the pie. Just a very small sliver would be estimated if you ask the patient, not controlled or poorly controlled. And then when you go do objective measures, most of that pie is not controlled, right? Really, a very only 29% could be considered controlled when you look at objective measures. And so that's a huge disconnect. And so you can't go in the room and just ask, hey, how's Jimmy's asthma doing? Because they're going to tell you, oh, he's doing pretty good. And then you walk out, and you missed your opportunity. Unless Now you can ask that because sometimes that's a helpful question, right? How's Jimmy's asthma? Oh, he's doing great. And then you start to ask some really pointed questions. Oh, when was the last time he needed his albuterol? Has he been on any prednisone? You start to kind of get to some more objective measures of disease severity. And then they start to say, oh, well, I mean, he uses albuterol. I mean, it was great. It was only 5 times this week instead of 10 times this week. And so now you know that one, he's not controlled and he's having a lot of symptoms, but you know what their version of normal is, right? And you know where you've got to go from there in terms of how big of a road in terms of just asthma control from a medical standpoint, but also from a conceptual standpoint, right? What they're processing as a normal for their life. It always amazes me what families will become sort of used to, what they'll live their life, right? I heard one adult pulmonologist was telling a story about a patient she was an adult, female. Her husband was in the military, so he would deploy very frequently, and they had young children. And she would set her alarm clock several times for the night to wake herself up because she had such bad asthma that she was scared that she was going to die in the middle of the night, and there was no one there to take care of their kids in the morning. They would wake up and find their mom dead. And so she just got used to setting her alarm to wake herself up just to make sure that she was still alive. And when they finally got her asthma under control and she was doing well and she came back to the pulmonologist, how grateful. But then also she said, and you know what, yesterday I took my kids to the park for the very first time, and so, I mean, it's those kinds of stories, but to them, if you had talked to that woman, a year or two before that, that was her life. That was what she was used to doing. And she, it was horrible, but it didn't really matter, right? So when we talk about shared decision-making, right, it's this idea of this sort of connection between the healthcare, or at least that the healthcare choice is both made by the patient as well as the healthcare provider, and knowing what the best available evidence is, right? And it's not an easy thing to do. And like I said, you got to do this in a busy clinic with 100 kids coming in and out of the door. So it takes a lot of multitasking and it takes a lot of reading, kind of behavior, right? So the point is taking care of patients better, but it's really to engage the parents or the patient, in kind of that partnership, right? To make better medical decisions. It's considered this core of kind of patient-centered care. But in pediatrics, at least what I do, it's unique, right? Because a lot of times we're talking about, patient-centered decision-making, but the patient isn't really involved, right? They're too young. So it's really parent/patient decision-making. And so depending upon their age, now you're dealing with two people because the patient may have their own opinion and then the parent may have their own, kind of an opinion. And then unfortunately, but it's a reality, we have a lot of kids who are, in split households. So now you've got a mom who's got one opinion and you got a dad that's got one opinion and they're 50-50 shared. So you've got to figure out, okay, well, I only 50% compliance isn't going to get me there. So I've got to figure out some way to educate both the mom and the dad when they're not coming to clinic at the same time, and get them kind of all on board. And it makes it very, very hard, right? And so, and a lot of the research, a lot of the studies looking at shared decision-making really more has been geared towards the adult literature. We don't have much on the pediatric side, but when they have identified sort of 9 core sort of goals around shared decision-making, right? So defining the problem, and there's a framework that I'll get to that sort of, kind of helped me sort of, I guess, organize my thoughts around this, but defining what that problem is really important. Like I said, having that discussion and realizing that not every decision that you make with a patient is the same level of importance, right? I mean, there's really only one option, and sometimes there's multiple options. So sort of trying to get a feel for how important is this decision that you're making with the patient, talking through those options, making sure they're educated, making sure they understand both the pros and the cons, that risks and benefits, and then talk about what they're, you want to involve them because, if they feel engaged, if they feel like they're part of that decision, and I tell them very, very routinely, I'm like, look, gone are the days where I just walk in, I don't wear a white coat, but walk in as the white coat and say, this is what I think you should do, and then drop the mic and walk out, right? It has to be a relationship, because if the parent doesn't buy in, if the parent doesn't understand and they leave that office, they're not going to, I can guarantee 100% they're not going to do what you want them to do. So it's got to be that you've got to get that engagement from the family. But you've got to get them to express or tell you what their understanding of that plan is as well. Because if you sort of have to have that double check. And then if there's not time, you can sort of pick what we need to work on right now and leave part of it for maybe the next visit, right? And so, we do it for all of these reasons, right? We do it because because we want to help involve them because it's considered right, because we don't want to be doing too much or too little, but we also want this to be a lifelong relationship. And so this sort of gets to some of the sort of pediatrics. So American Pediatrics actually came out with a framework around this sort of shared decision-making kind of model, recognizing that there isn't a lot in the pediatric world, right? And so this is sort of that model, and it looks kind of complicated, but I thought that it was interesting because once again, as I was thinking about this talk, I sort of had all these ideas and the way that I think about, when I'm walking into a room, and then I looked at this model, I'm like, okay, no, that's why it makes sense. I do it like that. And then, okay, it sort of helped to, I guess, put a framework around the way that I was thinking about patients. And so that at least helped me feel a little bit better about the way, I approach. But the idea is that, when you're sitting there with a patient, the first thing is there only one option, right? If there's only one option, then you're not really working through how do I make a decision? You're really just focusing on education and having them understand, right? So step one, is there more than one option that's available? And then once you decide, no, I've got a couple options available, it really is there a risk and a benefit? What's on the medical side, right? So, there is a reason why they're in the office to see you. There is a reason why they're coming to you with questions. You at some point, there is a level of expertise, a level of education, and that the families don't have. And it's not saying that you always have the right answer, but that should color a little bit of trying to help provide the family, with that information, right? And so does that medical side of the risks and the benefits favor one versus the other, right? And so if it really does favor something that you feel is more appropriate than another, that's what moves you over to that more physician-guided shared decision-making, right? This idea that you're not, ideally, it's not but you want to try to steer, sort of provide education so that they understand that you feel like that there is one treatment option that is much better than another treatment option, and sort of guide them hopefully in that direction, but that they're still engaged and part of that decision. Versus maybe an area where there isn't really one clear benefit, or it's not nearly, kind of as strong. And then in that case, really, it's very reasonable to really let the parent make the decision, entirely themselves. Do they want to do this or do they want to do that? And be very open, with them, that there really isn't a clear kind of winner or loser, if you will, from a pure medical, kind of standpoint. And this is the trick, right? As you get down to that step 3, part of that also then gets colored by sort of getting a feel for what the parent or what the family or what the child is, sort of what's their opinion of what you're trying to do, right? And this is where I think probably most of that multitasking kind of happens, right? Is you've got to sort of read the parent's face, the child's face. You've got to sort of read their mood and their affect to get a sense how pro medication in general are they, right? When you get some families in, and if it doesn't come from, an all organic single source family, whatever, thing, and they don't want anything that came from any pharmaceutical company whatsoever. And sometimes, depending upon the patient, if it's a story like we've heard today of these severe asthmatics, unfortunately, we just don't have options that are not going to be involved with somehow a pharmaceutical kind of medication, right? So you've got to get a feel of that and talk about what their concerns are. What are their, are they worried about something specific? Was it a specific experience that they had, or is it just a more broad concern? Is it, just sort of a cultural understanding? We actually had or still have a couple of medical assistants that are Indian, and they have been actually really helped us and helped me, in terms of eye-opening, sort of explaining some of the cultural differences, and really even kind of regional within India, South India versus North India versus different regions, around their understanding of a preventative medication versus a daily medication as even just part of their worldview. That there's some areas of India that they're perfectly fine with taking a medicine on a daily basis, and there's other areas where that's just not even in the way that they think about things. You have a problem, you fix it, and then you move on, and you don't do anything on a daily basis. Certainly within some of our Hispanic population, there's a similar sort of idea that once the symptoms stop, once the coughing stops, once the asthma symptoms stop, you stop the medications. And so sort of working through their sort of how they understand the role of a daily medicine and what they think is important, but then also in that process trying to help them define and understand what a problem is, right? You heard JoJo sort of talk that it wasn't until she had some of those severe symptoms that it finally dawned on her what impact it was having in terms of her life. And then she sought out the pulmonologist, she sought out that medical care, but sometimes it's not until they have that aha moment. And if you don't even know that they haven't had that aha moment, you're sort of behind the 8 ball, right? And then there's, there's of course, there's concern about financial costs. There's concern. I mean, so many times where mom's on board, but dad's not going to be on board, or vice versa, right? So the thing is, you got to ask, and you've got to get them to tell you in an honest and open way. And that is a trick sometimes, right? Because some families come into the clinic with very preconceived notions about what a physician is going to do or what a physician is going to say, and they already put walls up, and you've got to somehow break those walls down as you're working through, working through that. Because once again, if they don't buy in, if they don't agree, and I'll tell them that, I'm like, look, I understand that if you don't agree with what I'm laying out as a treatment plan, then you're going to walk out, and I know you're going to do something different, and that's not what I want. And so there's times that I shift my plan. It may not be the exact plan that if it were my child, how I would treat them, but it's a plan that at least I get them to agree to, that they're going to be compliant with, and I feel that it's safer than doing nothing. And I want to continue that open dialogue and that open discussion, right? And hopefully over time, depending upon how the patient, because I don't predict the future. I mean, I know what a treatment plan might be that I might recommend, but I'm not right 100% of the time. So, you get them to, the key is to continue that relationship, because if they walk out and they don't agree with you, and if there's no relationship, not only they're not going to do the plan, they're not coming back, and then you've really lost them. So that process, right, of sort of working through, deciding how important the decision is. I think in one of the articles they were talking about, like, the discussion around, should I take Claritin or not taking Claritin, right? I mean, so sometimes it depends on your allergy symptoms, but it's not really that key of a thing. So if they don't really want to take a medicine, and we're talking about something that's a low risk, I mean, it doesn't mean that everyone has to do everything that you say. But when you're talking about something that's more important, and these are children that have life-threatening or severe asthma, it's a different kind of picture. And I try to tell them that my job is not also to just sort of scare them into compliance. I'll tell stories. I'll try to make them understand, how severe or how significant this can be, but it's not to just sort of scare them. It's more to educate, but it's hard, right? And sometimes, if there's a language barrier, that can be very, very hard, because a lot of it comes from sort of speech and speech patterns and sort of those types of cues. And so I rely heavily on some of our translators that we use in clinic. They know, because they've heard me. They've heard do the kind of education. I know when something is going on when I say something very short, and the person who's helping, my MA is helping me, says a lot of stuff. And you're like, that's more than I said. But afterwards I'll ask, and she was worried about this, and so I explained this, and they already know. They've sort of know the things that I'm going to say, and maybe because it came from them and not me, there was better buy-in. I don't know, but it language barriers can be a major kind of impediment. But having somebody that knows you as a translator, having somebody that's worked with you in clinic as a translator, can be very, very helpful. That's where in the hospital, they don't let us use like charge nurses or other nurses. Like on my pulmonary floor, we're supposed to always use that language line thing. And I hate that, because it automatically takes any connection away. I mean, my charge nurses or my other nurses on the floor that speak Spanish or speak another language, I know them, they know me, and I feel a better connection as opposed to a random computer that we just wheel in there. So I think that was a step in the wrong direction. I maybe understand some of the medical legal reasons. So this sort of just kind of went through sort of what I just did verbally. Man, the animations did not go at all, but I just sort of walk through it, step by step, right? Just sort of talking about, is there more than one option? And sometimes is there really even a choice, right? The other challenge is that sometimes, and in asthma too, you think, oh, asthma is, we've known about asthma for a very long time. We've been managing it the same way for a very long time. And that's not really the case. This right now, I feel like in the last few years, and certainly moving forward, there's been big shifts in the fundamental way that we think about and treat asthma, right? This idea that we're really not going to be using short-acting beta agonists by themselves is really groundbreaking. Is very different than the way that we think about things, right? And as we get the data and the FDA comes along and we start being able to have access for our younger kids with the, albuterol plus an inhaled corticosteroid, we're going to have that, those options. And the idea is that these are medicines that are going to be safer, even if they're not using them correctly, right? So we hopefully at least try to put an end to some of the danger that we see with just overuse of short-acting beta agonists alone, that we've got some control of inflammation, right? But that, those shifts, as I go out and I talk to pediatricians and I talk to primary care providers, it's also, they sometimes think that it's a clear-cut choice, but it's not, right? I mean, the way that we think about these patients, the way we categorize these patients are kind of shifting and changing as we start to think more about even our mild intermittent asthmatics being at risk for significant exacerbations. And so sometimes that standard of care isn't quite as easy to determine. So, but trying to do your best to stay as educated, to understand what the sort of standard of care and what the information that you're providing, but then also trying to understand what the insurance framework is, right? What's covered, how's it covered? It can be very, very challenging, right? We have a girl in our office. She's like an amazing genie. I don't know how, I don't know how she does the job she does, but that's all she does is helps us get medicines authorized. But there's times, because it's so much work, that where in the past, like you might sit there like, well, I want QVAR because I want QVAR because that's what I want. But now it's a different, I'm like, well, if they cover Flovent and it's going to just be more work for my girl and she needs to be working on other things, it changes the way that I approach that patient now. And it was driven by insurance companies. But also just realizing that really there isn't, the QVAR wasn't better than the Flovent. It was just because I was being ornery. What you think is a clear-cut decision sometimes isn't so clear-cut. But then once you feel like that you're very educated, and you're, really make sure that those standard of cares kind of help set that standard, right? Make sure it's as evidence-based as possible. And then, like I said, sort of work through, educating the family about the evidence in terms of the risk, the benefit, the burden. Whether you feel like you need to be guiding the ship more, you can let the patient guide, or the parent kind of guide that ship more. Is really going to base, on a kind of a treatment by treatment basis, and a very specific kind of patient by patient basis. Really always recognizing that our primary obligation, right, is to promote the health and welfare of the patient. And then, sort of overall, sort of public health considerations as well. I think the biggest example of that is things like, both antibiotic stewardship and, kind of steroid stewardship, right? The right answer is not just to go in and prescribe something because you've got a really concerned mom and she's worried, and you just know, well, the fastest way out of this room is to give this mom steroids and antibiotics, and then I can move on to my next room. Yes, that's the fastest way out of the room. But it's not the right answer for the patient, and it's not the right answer for them long term, and for the community as a whole, right? Like I said, just trying to get a feel for what their sort of their kind of preference sensitivity is, like what are their options. We're really shifting away from that physician knows best sort of sense of paternalism, and really trying to respect the rights of the patient and incorporate that into the decision. But it's not just that we're abdicating our responsibility to help make decisions either, right? We don't just walk in, and I've seen this, right? I've been with adult pulmonologists that say, well, once I identify they need a biologic, I just give them the brochures for 3 or 4 of them, and I just tell them go home and do some research and decide which one you think works. And I don't agree with that. Now, maybe it's because I'm peds and we're a little more warm and fuzzy than that, but there's a reason why we sort of got to the place where we are, and our job is to help provide them that guidance, that information, in a way that helps them make the decision, right? And as opposed, I know a lot of physicians that can't decide what biologic to choose. So now you're going to rely on, a patient who doesn't have that years of experience to make the decision. It's not fair. So we're not just asking them what you want to do. There's sort of an art to also that sort of guidance, right? The ideal is that caring physician who integrates the information and the relevant values to make a recommendation, and through discussion, attempt to persuade the family to accept the recommendation as the intervention that best propose, for his or her overall well-being, right? So there's some gentle guide words, right? We are trying to persuade, we are trying to guide the conversation. We're doing this in a way that has the patient's best interest at heart, but we're not just sort of dictating what they should be doing, right? And realize also too that this changes over time, right? Both from a patient standpoint as they get older, right? We start to involve, the adolescents and those teenagers more into those decisions. And then, but just, I can't stress the importance of asking the mom or dad, when you start to get a little bit of pushback, just asking them why. What's the, and that not just tell me what, why, I get a feel for, and I'll be honest, I'll be like, I kind of get a feeling that you're not the most, kind of strong supporter of medication. It sounds like you've got some concern just about medications in general. Tell me why that is, Now, once again, I said this is a busy clinical practice, so sometimes they start going off on a tangent and you got to redirect because you don't have an hour and a half for them to tell you about whatever. But you got to hear it come from them. You can't make assumptions, or you're going to get it wrong. You'll get it right sometimes, but most of the time you'll get it wrong. And a lot of times, as they start to talk through, what I found is they start talking through, they start to hear themselves. And I've seen parents talk themselves into the plan that I had proposed, just as they're explaining why they weren't kind of for it, right? As they start to sort of verbalize what their concerns were, and they're like, well, okay, maybe it doesn't make as, when I say that out loud, it doesn't make as much sense, right? But I mean, it is time consuming. The other thing, at least that I find with both just education, when I meet an asthmatic for the first time, right, just educating about asthma symptoms, educating about asthma control, what our goals are, what we're looking for. The idea also is you got to realize that you only get this short period of time, right? The parent or the patient, they're the eyes and ears at home, right? Most of the time they come into clinic, they're asymptomatic, they're fine, right? It's 2 o'clock in the afternoon, it's not 2 o'clock in the morning, they're doing okay if it's not a sick work-in. So you have to educate them so that they can come back and give you meaningful information. If they don't know what to be looking for, and you expect them to come back and give you, important feedback, you're not going to get it, right? They have to know what they need to be looking for. They need to know what are the outcomes that you want to see. And it takes time, but if you put the effort in up front, if you educate that family up front, it pays off at the second visit or the third visit or the fourth visit, right? Whereas now you sort of have I don't want to say trained in a bad sense, but a trained family to understand that we're talking the same language. And so it pays off. Sometimes though that their parents aren't able to tell you why they're, scared about a plan. And so sometimes then if I really get a feel where it's not something that is going to be either easily kind of educatable, or it's not really a clearly defined sort of concern. They just are nervous about something. Then I start to sort of cone the time frame down. I'm like, well, look, okay, how about this? How about we talk about 1 month, right? I just want to see, let's see if we start this plan and I want to see you back in 1 month. I'm not saying we're going to do this for 6 months or for a year. If you see benefit, we might end up there, but I just need to know if this helps, or if it doesn't help, give me a month and let's come back and see what kind of change, and usually families can sort of get their head around doing something for 1 month. If you give them this like really clear, like, look, if there's no difference, if you don't agree, we can stop it. I don't want to have your child on medicines that you don't agree with. But they give you, it's getting that sort of initial foot in the door can really be helpful. So sometimes bringing it in, because they start, you start laying out something and you're talking about 6 months or a year or 2 years, that their eyes glaze over and they really start to freak out. So sometimes bring that time frame in, because once they see that benefit and that impact, it really makes a difference. And I mean, these things I feel comfortable doing. I'll be honest, some other physicians that I work with maybe aren't always as comfortable with having these kinds of open discussions, but that's why we also have some of our nurse practitioners and amazing care providers that can sometimes maybe work to our strengths and work to our weaknesses, and really help kind of recognize, like, that's not a discussion that Dr. So-and-so is really going to have. I know it's in his heart. I know that's what he wants, but let me see if I can kind of help provide and gather that information for them so that we can all come to the same decision. And so, right, this idea of that sort of shared continuum. And then, of course, the urgency, right? So I just outlined this a little more complicated, long, takes a while to build this relationship. Sometimes you're in the ICU setting and you've only got hours or you've only got a day or two. And so that sort of changes the whole framework of the discussion. Is this going to be just a one-time event? Usually, at least when we're talking about asthma, this is a chronic condition. So it's going to be something that's going to be ongoing. Is this something that, that the parent has to give, or something you're going to be doing in the office? And then is it likely to change over time? And I did it with 10 minutes to spare, I think, right? And so, I mean, I hope that was helpful, but I wanted for there to also be some time for any questions or anything, if anyone had about this approach, that framework. Does that make sense? I mean, I didn't want to just get up and just be like, this is what I think about when I go into a room. And, I felt like it was nice to sort of have a mental framework to hang it around. So hopefully that kind of helps in terms of organizing things. But I don't know if there's any questions or concerns or ways that you guys do things differently or think about things differently.
I just want to speak from my own experience working with at-risk teams from very diverse backgrounds. It is really important to get the parents on board. Mm-hmm. But how do you handle, diverse, say, not only cultures, but religions that might have differing views on certain interventions? How do you handle that?
Yeah. I mean, I think step one is if I can get them to verbalize what that concern, so that educate me, right? Because there might be an aspect that I'm not aware of. That, even within certain religious beliefs, there's different degrees of how, strongly they believe, how orthodox they are within that religious, belief. So once again, I tell them, help, educate me as to what, how you're looking at that. And then, how, I was not open-minded, but how flexible I am really, like I said, depends a bit on that sort of spectrum about how important I feel like this decision is to the health of the child, and that's the other thing too, is I'll tell the families, like, look, if there's ever a decision where I really think that this is life or death, this is something that I really feel strongly about, I promise you that I'm going to tell you. And if it's something that I don't think is life and death, if I feel like that there is a lot more sort of leeways we're having these decisions, I'm going to tell you then too, right? That this is an open dialogue, and usually you get sort of good feedback from that as well, right? If you make everything an emergency, then nothing becomes an emergency.
Yeah, I guess what I was saying is,
Yep.
I have quite a few religious Muslims in my classes now who are teaching in Queens, and some of them wear the full outfit, some just the head covering, and of course they're supposed to be doing the fitness thing.
Right.
So they're like, well, we're not going to the gym, or I'm doing this. I said, just walk.
Right.
All you have to do is keep track of your walking. You can go out, do it safe, do it before it's dark, do it in your neighborhood, keep track. And she was like, oh, fine. She didn't think she'd do it. Another one found an influencer on YouTube and did it at home in her living room because her parents didn't want her exercising outside. So I'm just saying we can be, sometimes people have this idea that, oh my God, if you get asthma treatment, you're going to have to get totally undressed, you're going to have to do this. If you exercise, you have to wear this outfit. So if we can get them on board to realize, no, you don't have to.
There's more than one way.
We just want you to be healthy and have a good quality of life and tell us what you're comfortable with. That's what I meant. If you, I don't know if you ever come up against that. But,
all the time, right?
Yeah,
and I try to communicate that rarely is there one way to answer this question. Rarely is there one way to get to that endpoint, right? And so finding that compromise, finding something that they feel comfortable with is important, but that it takes that discussion, right?
Yes, exactly. So you can change. I love what you said about patient perceptions.
Yeah.
I say it's the same thing with so many things.
Right.
We underestimate how much we eat, right? We overestimate how much we exercise, and we greatly are off base with our asthma control, right?
All the time.
So it's really important for the practitioner to know where the patient's coming from.
What
is their perception?
Right.
They might think they're just great, and they're not at all. So
because in the end, it's their asthma. It's not my asthma.
They're used to it.
Right.
So I think that's normal.
It's their asthma.
Exactly. So thank you. That's
obviously, education is key.
Right.
Do you use specific handouts for specific, like, we needed those inhalers, or would you actually just do the demonstrations? Or? I do
a lot of just manual demonstrations. So you saw me chuckle because I'm constantly in clinic. So I'm convinced that nobody reads anything anymore, right? You go to McDonald's and there's no menus. I'm like, what? How many hamburgers do you have? I can't even tell. It's a rotating video. Everything is video. Right. Everything is TikTok. Everything's YouTube. Everything is short format video. No one reads. So I can't tell you how many times I walk out of my clinic and I see the handouts that we gave, just kind of littered on the ground, right? So I do a lot of manual, just sort of showing them how to do it, or our nurse practitioners do a lot of just sort of showing them how to do it. One of my projects in the future, hopefully when I get the time, is I want to create a library of those educational things, and I know what they are, that I do multiple times a day, and create little QR codes and just like, hey, we went over this today, but here, here's the card. Just if you have questions later, just go watch this video, because that's how. And I'm feeling old now, right? Because I always say, like, that's how kids learn. But my parents are kids. I'm getting to that age now where I don't feel like I'm that old, but that's how the parents learn, right? They don't read. So I can give them handouts till I'm blue in the face, but it's showing them that I think the future is video. And there's actually, the quality of stuff, if you just say, go Google, that quality of what's online now is horrible. So we've got it. I think the onus is us to create, because also, the way our style, what we use or how we say is a little bit different. So, I want to tailor make it to the way that I explain to families, right? But I think it's all video and kind of showing them. And that's what we do in the hospital, right? I've got a script that the respiratory therapists, because some respiratory therapists are very comfortable, some are not as comfortable. So we created a script to guide their education that they do around sort of core educational topics, just so that we know that there's a baseline level of what's being told to the family, what's being shown to the family, and it didn't depend on how comfortable or uncomfortable, how new is a respiratory therapist, how old is a respiratory therapist. That there was at least now they can expound, with their expertise if they feel comfortable. but at least I wanted a baseline level of kind of competency.
You just mentioned Google.
Yeah.
How do you deal with Dr. Google?
I mean, once again, I asked them, where did they read that? Where did they see that? Right? We have to. We have to confront it, talk about how, they're just, that there is no control, over the quality of what's online, and that hopefully, and if there's something that they feel very committed to, ask them to print out what it was that their resource that they're printing. I'm not going to be able to go replicate their Google search and bring it in so we can talk about it, It's funny because on one end, right, they get all this horrible information and it really concerns me, but on the other end, I can't tell you how many families have come. And sometimes I want to hug the mom. They come in like, I came to see you because I went to your website and I read, I got on the page that says, who should see a pediatric pulmonologist? And I spent a lot of work in listing all these things out. And I had a mom that, I read that page, and that's why I came to see you. And I wanted to hug her because I was like, somebody read what I put on the internet, right? So Google helped me one time, yay. But, it's, sometimes they find their way. I think it was JoJo had said how she sought out the pulmonologist. I can't tell you now how often that happens. Yes, we get referred patients, but I feel like it's almost 50-50 that the families come find us as get referred. And so in that sense, at least finding their way to see a specialist is a good thing. But the good with the bad. Yes.
So as a general pediatrician, I like that idea of coming back in like a month. But could you speak how long it does take for things like Flovent to work or
Right.
Singulair, for instance? Like,
Right.
will that work in a month? Or?
Well, it depends a little bit on the severity, right? And it depends on it depends on the severity of the symptoms. It also depends upon the timing, like what are their triggers, right? So if you've got somebody who is, very viral triggered, right? It's like a younger kid, 4 or 5 year old with the preschool wheezers, but they have a lot of problems. So you decided, I really think a daily inhale, so Flovent or some daily inhale, corticosteroid is important, and it's the middle of the summer. But then I'll tell them, like, look, this may not be the best time, and we can have that discussion, right? So that time might be a little longer. Usually with our inhaled corticosteroids, we say at the very least 1 to 2 weeks. Once it depends on how frequent the symptoms are that are occurring. If they come in coughing or wheezing on a daily basis, a weekly basis, you're going to know within that month. If there is more of that, because remember, when we're managing symptoms, it's either symptom control or kind of risk, right, assessment, right? So those kids, it's not so much that they have problems all the time, but they end up in the emergency room or the PICU, and I tell them, like, look, what we're trying to modify is something that only happens 4 times a year. So you have to have that sort of open, kind of discussion. But if it's something that's more frequent, and if I already know that, then I already know I'm not going to go down the road of the 1 month sort of time frame if it's something, it's have to have that discussion. But so usually our daily, though, if the symptoms are pretty frequent, at least kind of a couple weeks, so you start to get a feel. I'm just trying to get them to do it. Other questions?
I just wanted to mention, something that you said earlier. It was, it's your asthma, not my asthma,
right.
but, and something that I tell my patients all the time is like, keep it writing, have a diary of the symptoms, when they happen, where they happening, and, just write it down, jot it down in some piece of paper, and when you go to your doctor, this is what's going on, because doctors don't live with you. So, and they don't know. So whatever you need to tell the doctor, just write it out if we forget. And it's just so important to, okay, my kid every time goes to the daycare, the beginning of the school year and stuff like that, I still, getting the colds and the asthma, or every time we go to the park, or, when he goes to grandma's. So things like that, those routines that you don't think is important, yes, they are important. So the doctor definitely needs to know what's going on in your life so they can help you.
So it's that pattern recognition that sometimes helps you, really kind of figure out what those new triggers are. And the other thing too, that a lot of times when you're getting to know these, families and kind of going through this, is they think they're going to come into clinic and then you have a test. And you're going to tell them that they have asthma, they don't have asthma, and then you got another, and then it's going to be like something black and white as that, right? And I quickly dispel them, like, look, the way we work through this is these conversations, right? I have to hear from you, you have to hear from me, and we have to work through. And so you've got to tell me about symptoms, you got to tell me about what's going on. We got to talk together about the timing and frequency and triggers and things. And because especially, and I hate to, I mean, I'm a dad. So, but when it's dad that comes in for the first time and they don't know anything, right? They just thought they were bringing the child to the clinic and then like to a vet clinic, right? I'm like, no, so we've got to get mom on the phone or do it, because this is not I don't have a magic 8-ball. It's all based on the conversation and the symptoms. I mean, yes, I can do PFTs. Yes, I can, but that, especially in the younger kids, especially in early asthma, it's all about the symptoms and it's about that conversation. And if dad can't have that conversation, then I need to talk to mom on the phone. So.
Okay, we had a dad bring the wrong twin. The wrong twin.
I had a mom one time ask if she could come and not bring the child. I was like, no. You've got to bring the patient to clinic. Right. Yep. And it's almost like even my nurse practitioners can attest, I think they're online, that if it's the dad that comes, that they're going to get the phone call from the mom, right, later that afternoon. Can you walk me through this treatment plan again? Because all I know is that dad came home and said, I don't know, I prescribed these meds, and we wrote it down in an action plan, but that's in the parking lot. So, so often, we know these, these are not new stories, right? It's all about communication. So, I hope this was helpful, right, to sort of talk through things. Cool.
Thank you again, Dr. Prpich, for this awesome talk and Q&A.